has been discussed in the light of the changing trend of its pathogenesis and hence a likely change in the trend of management. So let me embark upon what future holds. Well, friends, before I really talk about future, I was attending one of the Indian Orthopedic Association webinars, and there somebody said that steroids are not to be used. So let me first of all say that what are the various drugs which could be used by intra-articular route. Corticosteroids tops the list, hyaluronic acid, we have just now talked, and the other treatment modalities which are still in the stage of experimentation and has not got approval are TNF inhibitor, and mind you, very simple, capsaicin also has been found to be used intra-articularly. Topical use was existing for a long time. Intra-articular capsaicin injection has found to be useful, and it is said that the afferent nerve fibers within the joints, they get damaged, and hence the patient does not perceive it. The small molecules, their intra-articular use in the form of BNTA also has been used. Botulinum toxin, which normally is used for treatment in mainly the cerebral palsy patients, their intra-articular use have also been have achieved some success, but still is not recommended. Well, coming back to the topic of corticosteroids, I must tell that US FDA has approved corticosteroids for intra-articular injection, and they are in various forms: betamethasone acetate, dexamethasone, methylprednisolone, triamcinolone. Now, the intra-articular corticosteroid guidelines in osteoarthritis, they are not uniform recommendations. So, for knee osteoarthritis, hip, hand osteoarthritis, if we take these three into consideration, American College of Rheumatology and Arthritis Foundation guidelines in 2019, only 2 years earlier, they strongly recommended for knee and also for hip, and conditionally recommended for hand. OARC guidelines, again from 2019, they conditionally recommended it for knee and did not mention about hip and hand. AAOS had inconclusive or limited evidence in 2013 for the knee joint, but in 2017 they strongly said it should be used in the hip joint. Now coming to the recent advances in the management of osteoarthritis, I will be highlighting 2 points: introduction of new therapeutic agent, and number 2, introduction of evolution of sophisticated drug delivery system. Now friends, WNT signaling pathway is a pathway which exists and stimulates production of catabolic proteases. This is implicated in matrix degradation. It modulates differentiation of osteoblasts and chondrocytes. Now, following consequences of long-term intra-articular glucocorticoid, evolution of small molecule inhibitor of WNT signaling pathway was developed, which deserves our attention. For quite some time, this particular drug, which is a WNT pathway inhibitor, was known by the eponym SM04690, but now it has a name. It still has not been marketed, but Loresivivint. Loresivivint is a WNT pathway inhibitor, and it has disease modifying possibility. Now, this particular drug, when used intra-articularly, might cause cartilage regeneration and protection from cartilage catabolism. So, claims of significant difference in joint space width. Mind you, the standard of development of a DMOD drug is that if the drug can reduce or rather can increase the depth of the joint, that is to be approved. So here there is likely improvement in the joint space width, and as I had told you earlier, phase 2 trial is under process and will examine these things. Now the second point that I wanted to highlight, that there has been introduction of evolution of sophisticated drug delivery system. Normally what happens when we inject a steroid into the joint, the effects they start fading away within 2 to 4 weeks. So to prolong the action of glucocorticoid, if at all it has to be used, introduction of new delivery system known as polymicrospheres. In short, it is known as PLGA, polylactic glycolic acid. So this technological advance in targeted delivery approach has been approved by FDA for knee osteoarthritis. It is not pending approval, it is already approved. So we are repurposing an older existing drug in the new format, which again had an eponym FX006, but now it has a name Gilreta, and this is nothing but an extended release formulation of synthetic triamcinolone acetonide, which is loaded on PLGA microspheres. This maintains concentration in the joint for several months after a single dose, and pain relief is greater up to 5 to 10 weeks. So, as I told you, degree of joint space narrowing, which we know also by the cartogram MRI, which says what is the depth of the articular cartilage. So it can have a prognostic value as well, because subsequent TKR is positively a possibility within 15 years. How? For each 1 degree rate of tibial cartilage loss, 20% increased risk of undergoing TKR within 4 years. So cartogram becomes a useful investigative tool where we can prognosticate. Now the third thing that I want to say, and I have said it earlier on a platform which was conducted by Dr. Amarnath on osteoarthritis, that though this will be something like a loud mouth speaking, but maybe in coming 50 years, joint replacement may be a thing of the past, because there are gene therapy mechanisms available, and gene therapy also is intra-articular, and this gene therapy could be cell-based, as Dr. Manish Khanna has already said, but this gene therapy also is is also through the help of adenovirus. So this is initially developed for overcoming pharmacokinetic barriers, delivering biologics to the joints, great potential in treatment of diseases, including OA and definitely RA also. After 25 years of development, arthritis gene therapy is entering in clinical practice. US FDA in 2017 approved 3 new gene therapeutics, and South Korean Ministry of Food and Drug Safety approved first arthritis gene therapy, which goes by the name in VOSA. Now, gene transfer and expression of gene in a joint by residing cells, therapeutic gene products synthesized indigenously and continually be synthesized for potentially extended period of time. As I was just now telling, that adeno-associated virus has emerged as a popular vector for in vivo delivery. This virus is safe, effective, and less immunogenic. Now you can look into this, something like a spacecraft. This is the new gene, modified DNA, which is incorporated into the virus, is entering into the capsule, and finally the gene modifies the structures there inside the cell. Well, gene therapy, the intra-articular recombinant adenovirus transduces synovial lining cells as well as the chondrocytes throughout thickness of the articular cartilage. Considerable advantage in osteoarthritis, in which chondrocyte dysfunction has a key role. In VOSA, we already know, is the 5th gene therapy approved product for anywhere in the world, and it is second for a non-lethal disease. Well, this genetic medicine for arthritis may have a future and likely to be widely available by middle of the next decade. Friends, coming to the 4th point, small molecules. Well, the idea that progression of osteoarthritis is results because of imbalance between catabolic and anabolic factors. Now, there is something known as ECM, extracellular matrix. Degradation of extracellular matrix underlies loss of cartilage tissue in osteoarthritis. Now, BNTA, which is an intra-articular format of small molecule, this stimulates expression of extracellular matrix components while simultaneously suppresses the inflammatory mediators. Intra-articular injection of BNTA also delays the disease progression. Well, friends, we can see we did not talk about parathormone, but this is also one drug which helps as an anti-resorptive parathormone and other anti-resorptive drugs like strontium renylate, cathepsin K, and bisphosphonate, and they have their own path of action. And this is where osteoporosis is taken care of, what Dr. Dilip just now wanted to know. Now, coming to opioids, 2017, Yu et al. Said that there is a substantial risk and should be reserved only for patients not opting arthroplasty. So, limited role with eye on adverse effect must be seen. Now, friends, there is a silver lining in the medical management of osteoarthritis in sulfasalazine and small molecules. So, sulfasalazine and tofacitinib, they work on the protein portion of the articular chondrocytes, and it has opened new vista in the management. The novel functional aspect of tofacitinib is that claims to promote cartilage extracellular matrix generation and increases cellular levels of adenosine known to have anti-inflammatory effect. Now, sulfasalazine inhibits tumor necrosis factor alpha expression, so may reduce secretion of inflammatory cytokine such as interleukin IL-8. IL-8 is in fact a small cytokine which goes by the name of chemokine also. It might suppress B cell function as well. Well, in short, sulfasalazine has antibacterial effect, anti-inflammatory effect, and immunomodulatory effect as well. Well, these have been talked about, and as I have told you, that US FDA and EMA says that approval of DMOAD requires inhibition of loss in knee or hip space, joint space width on plain radiograph with relevant symptomatic benefit. And here so many products can be seen, which Dr. Raza has also talked about, which Dr. Elhens also talked about. NSAID is tramadol, duloxetine. Duloxetine is one drug which can be used in patients with persisting pain in spite of NSAID, and chondroitin. Well, other drugs we have already talked about, but here you will find colchicine, tranexamic acid, vitamin D, also hydroxychloroquine. Now, there are many drugs in the pipeline. Why have we thought of talking about osteoarthritis vis-a-vis the drugs that are in the pipeline? So if you look into them, that what are the various targets and what are the molecules, I will not read each one of them, but you can look at them, that so many are there in the pipeline. And the targets could be IL-1, TNF-alpha, toll-like receptor, other targets. And nerve growth factor is also one very important target on which tanezumab works. So even COX-2 and T2M, including metformin, is one drug which is likely to be effective. Similarly, statins, all the various statins are also being worked. And friends, I would like to conclude that what future holds are in the already proved in the hands of development of new therapeutic agent, Loresivivint, which is a WNT pathway inhibitor, introduction of evolution of sophisticated drug delivery system like PLGA, extended release formulation of FX006, Giloreta, which is synthetic triamcinolone, intra-articular gene therapy, small molecules targeting bone remodeling also raises hope for treating osteoporosis and osteoarthritis by regenerating both bone and articular cartilage. And last but not the least, inhibitor of MMP13 also is equally important and is likely to be topping the list of the drugs treating osteoarthritis. Friends, I will like to end with a quote which was there in one of the editorials written by Charles J. Malmud from Cleveland, Ohio, and it was written in the journal Future Drug Discovery in 2019. He says, however, I believe that one thing is certain. That one thing is certain. What? It was previously proposed that since many of the cellular events characteristic of rheumatoid arthritis overlap at some time with those in OA, which we have talked in this webinar, why not use those accumulated successes in the drug therapy of rheumatoid arthritis to treat osteoarthritis? I will read it once again. One thing is certain, it was previously proposed that since many of the cellular events characteristic of rheumatoid arthritis overlap at some time with those in osteoarthritis patients, why not use those accumulated successes in the drug therapy of rheumatoid arthritis to treat osteoarthritis? Friends, this was the stimulus to have this webinar, and I firmly hope that we have not talked anything which did not have a merit. We have talked about TNF-alpha inhibitors, but simultaneously we have said that none of the series TNF-alpha inhibitors have been successful till date, and these TNF inhibitors have been used intra-articularly. And any DMODs which are being developed, they will have to be used intra-articularly because the systemic effects may not allow their constant use. Thank you, friends. Thank you very much.